Repair with graft augmentation of a chronic retracted pectoralis major tendon tear. To begin, an anterior incision is made down to the underlying subcutaneous tissue over the inferior border of the clavicular head of the pectoralis major. The underlying clavicular head and sternal head are identified, and the location of the sternal head rupture is noted. A plane is then developed between the clavicular head and the underlying short head of the biceps. The long head of the biceps is identified and retracted. Attention is then turned medially to explore into the chest wall. The retracted stump of the pectoralis sternal head is palpated and mobilized with an Alice clamp. Then, working lateral to medial, multiple tag sutures are placed into the tendon to enhance mobilization, while aiming to reestablish the inferior border of the axillary fold. In the presence of adhesions, blunt and sharp dissection are used to release the pectoralis sternal head, while taking care to avoid injury to nearby neurovascular bundles. As the sternal head is released, more tag sutures are placed to pull traction laterally and evaluate the reducibility of the tendon to the humeral insertion. After mobilizing the sternal head, any degenerated or scarred tissue is removed to create a healthier tendon-bone interface and ensure optimal tendon healing and functional recovery. Next, the humeral insertion site is identified and prepared by drilling a guide wire followed by an 8 mm reamer. A fresh frozen Achilles allograft is then thawed and cut to reproduce the anatomic shape of the pectoralis major. The distal portion of the allograft is whip-stitched with fiber wire and prepared to fit into the 8 mm ream tunnel. The allograft is then loaded onto an 8 by 12 mm tenodesis screw and secured into the humeral insertion. The fiber wire is passed back through the screw and graft and tied for secondary fixation. The graft is cut to the appropriate length, ensuring that it lays flat over the native tissue. A free needle is then used to pass the tag sutures from the pectoralis major through the graft near its insertion on the humerus. This allows appropriate tensioning of the native muscle belly while securing the graft. While holding tension on the tag sutures, the graft is overlaid on the musculotendinous surface and its borders are stitched. Traction should continue to be held on the tag sutures until figure of 8 sutures are placed throughout the superior, middle, and inferior aspect of the graft. It is important to ensure that the sutures are placed through both the muscle tendon unit and the graft to integrate the graft into the sternal head of the pectoralis major. The traction on the tag sutures can be released after confirming the graft has been securely fixed to the native muscle belly. The surgeon should check for gapping to confirm proper tension of the tendon and to ensure restoration of the contour of the chest wall. Finally, the distal tag sutures are repassed through the graft and tied. Before closing, copious irrigation is carried out and the wound is soaked with betadine. The wound is closed in a standard layered fashion with 2-0 and 3-0 monocryl. Sterile dressings are applied and the patient is placed in a sling with the arm above the horizontal plane of the body and in slight internal rotation to take tension off of the repair. The patient is to remain in the sling for 8 weeks, after which they may begin active range of motion. They can be expected to resume full strengthening activities at 6 months post-op.